Today, 38th case series in peculiar cases in renal transplant. Today, joining me, my friend Dr. Rajan is here with me. So I'm Dr. Vel Arvind, moderator from we are practicing Trichy. We started this 3 years ago. It's going with full support from the audience as well as the local. Our friends are helping us a lot, especially the company people, making it uninterrupted show last 3.5 years. And today we have two presentations, very exciting. Though we have such kind of present earlier in our series, but this what we learn from every case is their approach, their the journey along with the patient, how they bring the success, and even the unsuccessful story also they share with us a great amount of learning for everyone. So we have one presentation from Dr. Subba's student Khamini. The another presentation from Akash is Muljibai Urological Institute of Medical Science, Nadiad. So we have three very interesting panelists, one from Madurai, one from Chennai, one from Bangalore. All are astute clinicians, dedicated nephrologists. They join here with us. Dr. Mohan Bhat from Bangalore Kaveri Hospital. Chandrasekaran, my close friend, my just 1 year junior to me, but he's been a good friend last 22 years and helping me some kind of. We always had a good time in the all conferences. So he's joined today after a long time. So he's from Chennai Apollo, and Dr. Andrew Rajiv from Madurai Meenakshi Mission Hospital. They are working along with Dr. Samit Kumar sir. So we are honored to have three of them today. Let's not waste time, and we'll begin with Dr. Khamini's show first. Please kickstart the show, Khamini.
Yes, sir. Yes.
Yeah, thank you.
Thank you, sir. Is my slides visible, sir?
Yeah.
Go ahead.
Yes. Yes.
Very clear, and voice is very clear. Go ahead.
Thank you, sir. Good evening, everyone. I am Dr. Khamini, nephrology registrar from Apollo Hospital, Chennai. I am presenting this case under the guidance of Dr. Subba, sir, senior consultant nephrologist, Apollo Hospitals, Chennai. The topic for today is no light at the end of the tunnel, a therapeutic dilemma. Here comes a 53-year-old Mrs. VB. She is a non-diabetic, known case of hypertension since 2012. She had normal renal function in 2012 with a serum creatinine of 1.1 mg per deciliter. She had a history of vision disturbances in the form of blurring of vision and diagnosed to have hypertensive retinopathy in 2015. Her antihypertensive medications were optimized at that time. She had a history of generalized weakness with anorexia, easy fatigability, and vomiting with loss of weight in March 2018. And she was detected to have acidemia for the first time with serum creatinine of 7.8 with anemia 7. She received blood transfusions 3 units, and urine albumin at the time was 2+ and RBCs were nil. All this was in the outside hospital in her native. She was initiated on hemodialysis through right non-tunneled IJC, and she was on thrice weekly hemodialysis. Left radiocephalic fistula was created, and it ended up in primary failure. During the course of hemodialysis, the non-tunnel catheter was changed to tunnel catheter in the same right AGV, and she was regular dialysis. She continued regular thrice weekly hemodialysis at her native, and she visited our center in May 2018 for opinion on renal transplantation. On examinations, his sponsored AVC was not elevated, PAL was present, bilateral pitting pedal was present, BB was 160/80, and her presentation and system examination were normal. In our center, urea was 37 with creat 4.7 with potassium 5.7 with the anemia of hemoglobin 10.8 gram per deciliter with the urine protein showing a 2+ and RBCs 1 to 3 with pulses 2 to 4. No history of abdominal surgeries in the past. She had near-term urine output of around 250 to 300 ml per day. No femoral punctures in the past. She received hepatitis B vaccine and pneumococcal vaccine. For on transplant worker, she had a sensitivity with 3 children born through normal vaginal delivery, and she had a history of blood transfusions in the past. Donor being daughter, HLA showed 2/12 mismatches in HLA B and DR1. CMV IgG was positive and varicella IgG was positive. PSA showed HLA class 2 positivity with value of 10,643 in May. On subsequent workup in November, it was 3,870. This donor was being referred because of HLA class 2 positivity. During the meantime, she had a history of fever in November with chills and rigors. Blood culture was sent at the time, and she was initiated on injection vancomycin 1 gram IV post-dialysis. The echo showed a homogeneous soft tissue attached to the catheter to query thrombus and query vegetation. She was initiated on anticoagulant. Blood culture showed growth of coagulase negative staphylococcus being a staph hominis and staph epidermis. The dunnel catheter was removed and it was reinserted again. Injection vancomycin was continued for 4 weeks and she was asymptomatic after that. She was registered for DDRT in Feb 2019. In 2021, she had a history of fever on and off, which was low grade with a history of weight loss of around 3 kg with swelling of leg in the right axilla. On examination, right axillary lymph node was palpable, approximately 3 cm in the medial one. So proceeded with FNAC, which showed expert MTB positivity with no rifampicin residence. Hence, she was initiated on renal modified dose of anti-tuberculous drugs. She continued to have high blood pressure after initiation of ATT. Hence, rifampicin was stopped and levofloxacin was started. In Feb 2022, PRA was positive for both class 1 and class 2. We worked up with another donor, being a nephew, 35 years male with no comorbidities. CDC was negative, HLA 4/12 match. DSA showed HLA class 2 positivity in July, value being 2,493, and in October 660. And he proceeded with the live donor renal transplant on 18th October 2022. ABO compatible, O positive to O positive. Total ischemia time was 1 hour 40 minutes. The end-to-end anastomosis between the external iliac vein and renal vein, and end-to-end anastomosis between the renal artery and the external artery. She had a good irisis on table and then the postoperative period. Injection regime used was injection ATG 150 mg over 3 days, that is 2.4 mg per kg, and methylprednisolone 3 gram over 3 days. The NADIC react was 0.8 on POD4 with TAC levels 12.5 mg per ml. She was discharged on POD5 with the following medications: TAC 3 mg BD, MMF 500 mg BD, and prednisolone 20 mg BD with prophylaxis Valgan and Bactrim. She was readmitted on POD6 with history of 1 episode of vomiting and reduced urine output, no other positive history. On POD6, her blood pressure was 160/100. In suspicion of cyanide toxicity, TAC was stopped, and the renal artery kidney Doppler done at the time revealed size of transplant kidney 10.3 into 5 cm, and she had a high resistance flow. TAC levels on the next day was 7 nanogram per ml. Biopsy was done on POD7, which revealed C4D positivity 90% with acute ABMR G1 and PTC2. DSA done revealed class 1 257 and class 2 13,300. Hence proceeded with the plasma exchange, a total of around 6 cycles with IVIG 60 grams. In the meantime, she had a fever on POD 11 and proceeded with antibiotic minoprem and blood culture and urine culture has sent. Subsequently, her urine output decreased, and hence the second biopsy was done, which revealed acute TCMR along with the ABMR. This is her band score I3, G1, PTC1, C4, D3. DSA class 10 or POD 14 revealed class 1 of 355 and class 2 was further increased when compared to the previous value 17,763. Her urine output was still low and she was on hemodialysis along with the plasma exchange and the IVIG. Urine culture done at that time revealed the growth of E. coli, insignificant colonies, 3,000 colony forming unit, and it was S.Vel and carbapenems positivity. She was discharged on POD 16. She received 1 dose of rituximab 600 mg on POD 16. She was discharged with the following medications. On the follow-up, her urine output improved and creatinine was on the declining trend, and the tacrolimus dose was increased to 1 mg BD. She was asymptomatic from November 2022 to February 2023 with the creat of 1.2 to 1.3. She had a history of fever and poor oral intake for 3 days, and she had worsening acidemia from 1.3 to 1.5 and 1.7 and 1.8 on admission. With the leukocytosis 25,000. She was admitted and renal biopsy was done on 22nd Feb 2023 along with the blood cultures and the urine cultures. It revealed the neutrophil infiltrates in the interstitium. It was a diffuse interstitial infiltrates with C4D negativity, suspicion of infection. graft pyelonephritis. Urine culture showed growth of carbapenem-resistant Klebsiella pneumonia, more than 1 lakh colony-forming units. She was treated with ceftazidime avibactam 2.5 gram BD along with the aztreonam 2 gram BD for the period of 14 days, followed by ceftazidime avibactam 2.5 gram TDS for 1 week, and it was stopped. And she was asymptomatic. She was continued with nitrofurantoin 100 mg BD. Her creatinine improved from 1.8 to 1. And she was asymptomatic for 2 months. Again, in 26th April, she had a history of fever with chills and rigors for 2 days. Her creatinine worsened to 1.5 with leukocytosis, total count being 16,000. Again, the urine culture growth of Klebsiella pneumonia with pan resistance. She was treated with ceftazidime avibactam aztreonam because the synergy test was positive at the time, and she was treated for around 14 days, followed by doxycycline 100 mg BD, and it was advised to continue for 3 months. ATT was stopped because she was on ATG for 18 months. She was on prednisolone, tacrolimus, morphilet, and Bactrim at the time, and her creatinine improved to 0.9. Subsequently, her creat was stable by 1.1 to 1.3. She had a history of, again, UTI in July 2023. At the time, she had equal egg growth with more than 1 lakh colony-forming units. She was sensitive to imipenem and meropenem. She was initiated on meropenem IV 5 days, followed by ferropenem 300 mg BD. Subsequently, in August, October, the creat was maintaining around 1.3 to 1.4. In October, her urine culture showed significant colony count only of Klebsiella. She was on nitrofurantoin 100 mg BD for around 3 to 4 months. She came on Feb 2024 2nd. She had difficulty in holding objects and difficulty in getting up from bed for the past 1 week with a history of swelling of both the lower limbs for 1 week. At the time, her creat was 1.3 and the blood pressure was 140/80 mmHg. She was evaluated for the neuropathy. The nerve conduction study revealed sensory motor neuropathy. The cause was we don't know. We elaborate workup first done, but nothing revealed to be positive. Drug history had a history of nitrofurantoin and tacrolimus. A few studies have showed because of association between nitrofurantoin and tacrolimus, both the drugs were stopped, and she was initiated on everolimus 0.5 mg BD. Her medications at that time was prednisolone, MMF, everolimus, Bactrim DS, and antihypertensive medications. 1 month later, she presented with fever and cough for 1 day, along with creatinine 1.3. She was treated with antivirals and antibiotics. Everolimus was stopped at that time. Urine culture at that time growth of E. coli with 10,000 colony-forming units. And after 2 weeks, she had extensive rashes all over the body. And at the time, creat was normal. The cause still unknown. We evaluated for the same. Multiple workups were done. All the infectious causes ruled out. Vasculitis package was negative. Few articles were suggestive of Bactrim causing rashes. So we have stopped it and we have waited for a few days, and no rashes were there. And if there is a plan for skin biopsy, if the rashes reappear, but there is no rashes after that. In April 2024, she had a swelling of lower limbs, which was progressively increasing. Urine spot PCR at the time was 4.1. She was initiated on ARBs, losartan 50 mg BD. At the time, also, growth of Klebsiella was seen in urine culture, but it was only 10,000 colony-forming units. In May, she had a history of fever for 3 days with chills and rigors. She was evaluated at her hometown. It revealed the growth of Klebsiella pneumonia. Creat was worsening from 1.5 to 1.6 and 1.9 and 2.1. She was treated with cefoperazone sulbactam 1.5 gram BD for 7 days. Still, she had fever with chills and rigors, hence modified to ertapenem 1 gram OD for 14 days, and she was better. She came to Apollo after 14 days. At the time, symptoms better, but her creat was worsened from 1.8 to 2.1. Urine culture revealed growth of Klebsiella with pan-sensitive. Count was around 10,000, along with the Proteus mirabilis. She was treated with rigicycline here, and because of worsening creatinine and leukocytosis, she was admitted. This is her renal Doppler and the transplant kidney. It was good at the time. We proceeded with a biopsy, which revealed the normal-looking glomerulus with mild mesangial expansion with splitting of the basement membrane. Coming to the interstitial tubules, there is a tubulitis along with the interstitial infiltrates comprising of lymphocytes, neutrophils, and the eosinophils. This is the comments given by the pathologist. There is a features of chronic antibody-mediated infection because of the segmented clipping of the basement membrane, along with the severe interstitial nephritis suggestive of query drug-induced or infective etiology. They asked to work up for BK virus. BK virus panel was negative. Query ertapenem was the cause because that is a new drug introduced between the February first week and the third week. So maybe possibility of ertapenem induced interstitial nephritis was suggested, and she was given 3 doses of methylprednisolone 500 mg. Her creatinine was improving from 2.7 to 1.7. After that 3 doses of IV prednisolone, she was given oral visolone 16 mg BD and MMF. June, she was symptomatically better and creat was around 1.6. The steroids were stable and was on prednisolone 10 mg OD. Subsequently, after 2 weeks, she presented with easy fatigability, poor oral intake, and difficulty in moving limbs with drowsiness for 2 days. At that time, her creat worsened to 2 with leukocytosis being 20,840. Again, the blood culture showed Klebsiella pneumonia with the urine culture showing Proteus millabris more than 1 lakh coliform units along with the Klebsiella pneumonia. MMF was stopped at the time. Since Klebsiella was pan-sensitive at the time, she was initially treated with meropenem followed by amikacin for 250 mg stat followed by 120 mg BD on visolone and antihypertensive medications. This is her follow-up chart. Her creatinine improved from 2 to 1.3. She was on ciprofloxacin BD for around 10 days. Again, after few days, maybe 1 week, her creatinine worsened from 1.3 to 1.5, 1.6, and 1.8. At that time, again, the culture was sent. It was a pan-resistant Klebsiella. Hence, she was treated with Zavicefta and Astrodome BD for 5 days. Still, the worsening creatinine was there. So, the Zavicefta Astrodome, after 5 days, it was stopped. And there was an improvement in the creatinine. After 2 days, she again presented to our US center with fever and chills for 2 days. Had metabolic acidosis with bicarb of 11, and she was treated with isotonic bicarb. Chest X-ray revealed the right middle zone haziness. This was her X-ray. She was treated with antivirals. She improved after 3 days. 2 days back, this is her X-ray. During that admission, we also did ultrasound and transplant kidney Doppler. It was good with the size of 10.6 centimeter into 5.3 centimeter. Transplant kidney Doppler also good with RA of 0.41. After the discharge, she was treated with augmentin duo 1 gram for 1 week with the antivirals and visolone alone, no other immunosuppressive medications along with the supportive medications. Uroflometry after that admission was good with the Qmax of 15.2 ml per second with water volume 203 ml with the water duration of 27 seconds. At present, yesterday her creat was 1.3 with urea 54. Total count was 12,250 with hemoglobin 9.2 and platelets 3,56,000. And she is stable with no other complaints. As a whole, she is a case of systemic hypertension with chronic kidney disease, stage 5D, previously on maintenance hemodialysis with basic disease of hypertension nephrosclerosis, had history of tuberculosis in 2021, treated for around 18 months, underwent live donor renal transplant in 2022, had antibody-mediated rejection along with acute TCL-mediated rejection in 2022, received 6 cycles of plasma exchange along with IVIG and the rituximab, and her reached her normal creat of 1.2 to 1.3, had a history of drug-induced sensorimotor neuropathy, query nitrofurantoin or query tocralmus, with history of drug-induced interstitial nephritis, query ertapenem, with history of chronic ABMR with IFTA 20 to 30%, had history of recurrent complicated UTI with graft pyelonephritis, the organism being CR Klebsiella pneumonia. Recently got admitted for lower respiratory tract infection, probably viral, and she improved with the antivirals. The question is, what will be the next drug if she develops urinary tract infection? Almost we have given all the medications for the urinary tract infection. Still, she is presenting with recurrent UTI. What will be the next step if she presents with UTI? Are there any ways to prevent it? Coming to the discussion, what is a complicated and recurrent UTI in renal transplant recipients? Complicated UTI is nothing but the fever, pain in the region of the transplant kidney, chills, and bacteremia with the same organism in the blood and the urine cultures with the renal impairment, with the laboratory tests showing more than 1 lakh colony forming units movement and more than 10,000 colony forming units in men, with single urine sample collected post catheterization in the woman. Recurrent UTI is nothing but at least 3 episodes of symptomatic UTI within 12 months or 2 episodes within last 6 months, with the colony forming units of 10,000 to the 10 to the power of 3. Coming to the pathogenesis, uropathogenic bacteria in the intestine is the one which enters the bladder through the urethra. These bacteria use the adhesins that help them to adhere to the bladder epithelial cells. Two things I have to insist: biofilm and intracellular bacterial communities. Biofilm is nothing but the settled communities of the microorganisms whose cells are embedded in the matrix of extracellular polymeric substances. These biofilms protect from the host immune responses, and it facilitates the microorganism's survival, and it provides increased availability of nutrients and better opportunities for the cellular communication and exchange of the genetic material. Because of this, there is an ineffectiveness of the antibiotic treatment, blocking their access to the cells lying in the deeper layers of the biofilm matrix and generating the drug resistance. The newest intracellular bacterial communities, there's nothing but the intracellular biofilm, in which the uropathogenic strains enter the cytosol of the cells, lining the bladder surface, and it proliferates rapidly, forming a biofilm-like complex with large intracellular aggregates containing up to 10 to the power 6 bacteria. All these be mostly in the intermediate and the basal cells of the bladder, and these bacteria enter the dormant state and becoming an inactive or resting intracellular reservoir that may periodically become active and causes UTI. What is the role of probiotics in recurrent UTI? We have this knowledge is based on the pathogens that cause most of the urogenital infections progress from the rectum to the perineal region and to the vagina and the mesentery. The clinical studies have demonstrated that oral administration of lactobacillus can demonstrate its effect after reaching the vagina. The lactobacillus strains appears to have 3 distinct modes of action, one being bacteriostatic and the other being bactericidal, and because of the lactobacillus byproducts. The bacteriostatic effect is caused by direct nutritional and attachment site competition between the probiotics and the uropathogens. The bactericidal action is mediated through the secretion of antimicrobial peptides known as bacteriocin and the immunoglobulins. Byproducts being lactic acid and the hydrogen peroxide, it suppresses the valence gene expression in the common uropathogens. Conclusion, they have given that the prophylactic use of vaginal probiotics alone or in combination with oral probiotics are found to be effective in preventing symptomatic UTI recurrence. But these studies are done only in the pre-menopausal women, not in the post-transplant patients. This is a recent randomized double-blind placebo-controlled trial examination in the Infectious Disease Journal, in which they have 4 groups. First one is oral placebo and the vaginal placebo. Second was oral probiotic and vaginal placebo. Third one is the vaginal probiotic and the oral placebo. Fourth is oral probiotic along with the vaginal lactobacillus. In this, the incidence of UTI at that 4 months showed G4, that is the group 4, that is oral probiotic along with the vaginal probiotic being lesser when compared to the other groups. So they suggest the prophylactic supplementation of vaginal along with the oral probiotics in premenopausal women in preventing recurrent symptomatic UTIs. The investigational approach is fecal transplant therapy, nothing but the fecal microbiota therapy, in which there is a transfer from the healthy donor, the fecal bacteria that from this healthy donor is processed and it made into pills or a liquid and is delivered to the patient through the nose or the mouth or whether the colonoscopy. There's only one article in the literature showing the fecal microbiota transplant being effective for Klebsiella pneumonia infection in the renal transplantation. She's a 37-year female. 1 month after the kidney transplant, she had a Klebsiella infection, both in the wound, blood, and the urine. She underwent fecal microbiota transplant from the donor, I think brother. And after 70 days, there is an improvement in her wound healing and this disappearance of the Klebsiella pneumonia in both the blood and the urine. This is her timeline actually. Thank you.
Oh, thank you, Khamini.
Good.
Can you unshare? So now Sir can intervene.
See the
Khamini, please unshare the slides. Okay,
Yes,
please.
sir.
Yeah, see, the problem is that many times we got away with a class 2 antibodies positive in a patient, particularly when the count is not much. We have done few transplants with the class 2 antibodies positive more than 1,000, but this time it was only 600. Thought we would get away. So that was the first hit we had it. And then she had a very severe rejection, both ABMR and T-cell mediated rejection. Luckily, she responded to treatment. But what happened was that then she started picking up urinary tract infections. Despite treating them, she used to continuously get infections. The other thing, the problem we had with her was that she was allergic to so many drugs. Any drug we give her, she used to get a reaction. Some even very small like ciprofloxacin, even nitrofurantoin, and even any antibiotic. So what happened was when she had the first 2 infections, when you put on nitrofurantoin, she tolerated well. There was no infection for a period of about 6 months. Unfortunately, she developed a severe radiculoneuropathy, and which we thought could be related to nitrofurantoin. We had to stop it. Subsequently, she made about 60% recovery, but still there is a 40% deficit is still there. And then to give her any medication was a big problem. And then she came back with a acute drug-induced interstitial nephritis, possibly related to ertapenem. Then we had to give her a high-dose steroids to bring her back from that. That resulted in her, I think, significant loss of immunity. And then now she started picking up even a small, infections becoming big, severe now. She's only on steroids. Her creatinine is normal, but I'm not sure whether we would be able to move on like this. It's almost 2 years since she had a transplant, and we still don't see a light at the end of the tunnel. That's our problem.
She's without immunosuppressant for 5 months, right, sir?
Yes.
So you stopped everolimus in March 2024.
Yes. The problem is now also the over immunosuppression now.
Yes,
because we
sir.
had to give her steroids for a long time. So
Chandrasekaran?
Yeah.
May I invite
Sir, hats off to you, sir. Hats off to you, sir. I would have, I would have stepped back aside after some time because of respiration. I would have not pulsed her repeatedly, right? So I would have taken a back step. Hats off to you. You just
we hung on
went
to
ahead
her.
with. Yes, sir.
We hung on to her.
Yes, sir.
Yes,
Great.
that's right. But it all because of over immunosuppression only. We know that.
Yeah.
But she was asking questions about what antibiotics we can use, right? So we had a similar situation in Apollo Vanagaram.
We at the present, no, we don't know what drug she is sensitive to. So we don't have any antibiotics to give to her, and we don't have any antibiotics to give it as a prophylaxis now. Because
prophylaxis is okay, sir.
She's sensitive to all these medications. Ciprofloxacin is sensitive. She's sensitive to nitrofurantoin. She's sensitive to the ferropenum. So we don't have a prophylactic drug also to give it to her in case she gets a future infections.
Okay. Sir, we had a similar situation in Apollo Vanagaram, one of the first few cases. Patient had a first transplant. On 8th day, ABMR was rejected. We just went again with rituximab and plasmapheresis IVIG. After 14 days, she developed severe resistant pseudomonas.
Yeah.
So resistant to all drugs, and she became dialysis dependent, but she was throwing fever like 1 or 2, 1 or 3 every day. So at the time, we just searched the literature and we found out there is cefepime-zidebactam is available. It's in clinical trial. It's at OCOT, sir, but it is
Yeah.
not.
Yeah. Approved.
It is not. Yeah, it is approved, but we can get it on compassionate grounds. So we have to send a
I don't
request
think
to.
that drug is approved in by DCI in India.
DCI is approved, sir.
Approved, okay.
We have to send a letter.
Okay.
Before that, we have to get
on compassionate ground, not on the regularly.
compassionate. That's what compassionate grounds.
Yeah.
No, we had it passed through the Institutional Ethics Committee, Apollo Institutional Ethics Committee, and then we sent a request. They even sent a drug. By the time she recovered and repeat culture was negative, so it went unused.
Okay. If you
The
have it,
problem is
keep it in stock. We might use them.
we cannot, sir. We cannot because it is a stringent one. We have to send the report every day.
Okay.
We have to, okay, and procuring it and sending it back, shipping it. It has to come from Italy once. So,
Chandrasekaran, what is the drug? Cefepime-avibactam. What is that?
cefepime-zidebactam. Cefepime-zidebactam.
Zidebactam. Okay.
It is beta-lactam and beta-lactam enhancer.
Yeah. Yeah.
So,
okay. Thanks.
it has been there for more than 9 months now.
Yeah.
Okay. Ramanji, please go ahead.
Yeah, hats off to the team looking after her. They've been very brave. But I just I just wanted to find out. I'm sorry, I was busy trying to multitask, so I missed a few things. If Dr. Khamini can tell me who is the donor here?
Nephew, sir.
Cousin.
Nephew.
Nephew.
Cousin, is it? Yeah. And how many pregnancies and miscarriages, etc. she's had?
No miscarriage, sir. 3 children. Normal vaginal delivery.
3
2 daughters and 1 son.
She received blood transfusions.
Yes, sir. 3 units.
3 units blood transfusion. Now, usually we tend to, with people with recurrent infections, we try to take them off the, anti-metabolites. Now I know she's just on steroid, but then I know she had a reaction, some neuropathy, and you suspected tacrolimus could be the cause, but also nitrofurantoin was also suspected. Why not, why not put her on a very low dose tacrolimus and low dose steroid rather than keep her on MMF? I know you stopped MMF some time ago, but she was on MMF for a period of time. MMF and steroid.
We might start and the immunosuppression soon, but at the moment she is not off. That doesn't mean that we are not going to start her. We will probably start her on immunosuppression in the near future. But the problem is she just recovered from a lower severe viral infection, which while only on 10 milligrams of prednisolone. That means it suggests that it's still quite an immunosuppressive state. So we would definitely start in the future, but I cannot promise you when that will be. I think based on her clinical condition, we might we'll see.
Yeah. So most of the times it is the amount of steroid that we use which is more harmful than the other immunosuppression. So I was just wondering whether we can reduce the steroid, and then as you said and everybody pointed out, it's the amount of immunosuppression cumulative that she's had, which she required, or should we say, because she's had so many immunological insults apart from the infection. And things to look at in terms of recurrent UTIs is constipation, sexual activity, all those things is something that we have to also look at, because she is somebody who is sensitive to most of the antibiotics.
No, she's a widow. And so she's 50. She's a widow, basically widow with 3 children. But we just brought her around. Now we are thinking of all the possibilities. What way we could help her out in the future. So what are the things we probably put her on a high dose of probiotics and see what else could be done. Because I'm pretty sure we won't be able to give her any antibiotics, either as a prophylaxis or as a treatment, because she's either allergic to these drugs or she's resistant to these antibiotics.
Great, sir. Great. Andrew?
Yes.
What do you do in this situation? Sitting down in South with a social string budget, and the patient are very poor, or most of the patients are done on scheme basis. So what will be your position to treat this patient?
Yes, sir. Very good presentation by the Dr. Khamini, and I would congratulate sir for a very well managed case. Just a few queries to the presenter and to sir. Like the patient had a DSA positivity, class 2 was positive before transplant. Looking back in hindsight, will desensitization would have made any difference?
Yeah, see, we thought over it, because what happened was that previously we had done a few transplants like that, who had a low class 2 antibody. We were not expecting to have a very high degree of rejection, and we thought that the induction therapy would take care of it. It was actually, at the hindsight, it was a mistake. We should have probably done a desensitization, at least few sessions before we go ahead with the transplant. I would agree with your point here. I think we took it granted that nothing would happen, because we got away with it few times in the past.
Okay, sir. Sir, regarding the recurrent UTI, sir, prior to transplant, was there any history of UTI, sir, for the patient prior to transplant?
No history of UTI before.
Okay. Regarding management of recurrent UTI, very difficult, sir. Many drugs have been resistant for her. So as sir has done, that's the only thing we could do, I think, for this patient. Nothing else could have been done. The methylprednisolone pulses were given, I think, the second time also, probably after the diagnosis of graft nephritis. If
that is interstitial nephritis.
Yeah,
that is ertapenem-induced acute interstitial nephritis she was very sick, so we had to give her a high dose steroids for some time.
Okay,
I think we gave it as injections and then as a tablets for about a month.
Okay. Thank you, sir.
Some Cefepime Cidibactam, I think, has shared a message. It's a good thing. We learned few things, new things today. So, Ram, would you like to add anything to this? What would be your line of management? And
No, I'm very glad that I'm washing my hands of transplant. I cannot stand the stress of transplant anymore. Congrats to everyone who wants to continue.
Okay. So,
can I ask one question?
Rajan, please. Okay.
Yeah. Congratulations to Subba Rao sir for managing the difficult case, and you're going to manage this case along. So one thing is regarding the DSA positivity, class 2, even though your DSA is low, there are some phenomena of shared epitopes actually. Many times we would think that the MFI is low and we are get away with transplants. Many times what happens, there will be shared epitopes where the antibodies bind across the epitopes in a low quantity actually. So if you find that kind of shared epitope by correct software, I think many of them are using actually. So if you find that, then it will be, it won't be the reflection of the original antibody status. Actually.
No, what happened in this patient was that while we are waiting for the transplant, the MFA started dropping. So it came from 3,000 to 600. I thought this is the right time to go ahead with the transplant. Yes, okay. That's. I think that was the oversight. I think we should have done something at that time.
Sir. Another one point is that tacrolimus, withholding tacrolimus in that kind of a patient who had a ABMR and ACR is somewhat critical. Actually, what we are doing, we are reducing the important vital agent. And every time the patient goes for the rejection, we are treating the patient with the over immunosuppression. So
yeah, I think
the
the immunosuppression has never been the idea is not to stop them permanently. This is to get over the crisis. I think she should be back on immunosuppression as soon as possible, because the only thing is that to say that it's over immunosuppression, proteinuria started reducing, creatinine started improving. So the active ABMR is not there. Whatever it is there on the biopsy of that, it's suggestive of an old ABMR. There's no fresh ABMR here. Her proteinuria was initially 8 grams. It's now about 1.8 grams now. And the creatinine is coming down. So I think for the time being, we are getting away without immunosuppression. But I think pretty sure that she would be requiring immunosuppression very soon.
True, sir.
Rajan.
Yes, sir. Yeah.
Do you think
Yes,
is there any cutoff? Is there any cutoff for MFIs in DSA pre-transplant? I don't think so. It all depends upon how do you interpret it? How do you react to the graft?
Yeah.
Yeah.
So it's better to see that actually when you have that kind of MF you are in doubt actually. So you need to have that software and to look for the shared epitopes. Many times the original MFI won't be given actually. That shared epitopes will take up the antibody, so it will be giving a false low MFI. Suppose it would have been
then that should be done for each and every case, right?
No.
It's not only if you have doubt we have to do.
No, if you have a single bead DSA positive, if you have a DSA positive, then it is
SAB positive. Yeah. Okay.
What many times NGS we are doing NGS, HLA, that is means that is 2 digits actually. Suppose if it is HLA 0304, sometimes you will get a antibody against 0304. Like it won't be a donor DSA, but it might be to the different thing. Shared epitope. So in that case, we have to look whether is there original DSA is that DSA originally she is having a DSA or not. You have to see that actually, so that we can plan a desensitization therapy prior to transplant. Anything done after transplant going to be detrimental with the patient actually.
Very true. Okay. Andrewji, anything you want to add? We will move on to next case.
Yes.
You want to add anything?
No,
Hello?
sir. You can proceed.
With this, I should congratulate Khamini because she has brought too many things in her discussion. It's very nice. She talked about the other than extracellular protein substance, that is matrix, there is something called intracellular biofilm. And she touched about a very important point, which has been in the discussion last 1 year, especially from the European countries, and the fecal microbiota transplant. That's a thing, is a new kind of thing. She talked about the carbapenem resistant Klebsiella pneumoniae, and ultimately she showed some study result also. I think future is going to be different. I'm happy about that. She brought too many good things at the end of her discussions. Thanks, Khamini, and thanks, Subba sir. And I think she presented without dropping any kind of information, so that we could catch entire course of things clearly, sir. Thanks for that, sir. Sometimes we skip and we go to the other things, but she made it a point.
Well,
please, Chandrasekaran.
Well, kindly excuse me. I have another meeting.
Yeah, please go ahead. Thanks for joining. Thanks, Chandrasekaran.
Thank you.
Sakti, I'll give you 30 seconds. Finish it up.
Thank you.
Yes, sir. Sir, what Rajan sir was referring to is epitopes, sir. Public and private epitopes. If we look at the SAB and the MFIs are mostly restricted to the public epitopes, then as sir said, we have to look at the cross-reactive epitope groups. The phenomenon is sharing, sir. The MFI might be actually high than what it is being shown there. So if it is private epitopes, then it is reliable. So an immunologist can tell you whether it's private or public epitope. So that if the patient's PRA is very high, which means the chance of having public epitope is very high. I'll finish with that, sir. Thank you, sir.
I think sir has realized that. Subba sir said no. Ultimately, there is a thing. I think it should have done it. That's what he said. Sir said. Okay. Any thanks thing, and Rajan, thanks. We'll move on to the next case. Akash. Yeah. Thanks. Yeah, your slide is visible. Am
I audible?
Yeah, yes, Akash. Please.
Okay, sir.
I request
So,
extra
Dr.
people
Akash Pandya
keep the
from,
mic in mute so that the external sounds may not interfere. And all the audience here, please keep your audio mute, please.
so I'm audible, right, sir?
Akash, you are
Yeah,
audible.
yeah,
You are
go
audible.
ahead, go ahead.
Your slides are very
Okay,
clear.
sir.
Okay, please go ahead.
Okay, sir. Okay. Thank you. I'm Dr. Akash Pandya from Murjibhai Patel Urological Hospital. I recently joined as a consultant nephrologist here. I've done my specialty from here only. So today's topic is parvovirus infection post-renal transplant. And this topic is close to me because there are two good papers from India. One was published by my thesis guide, Dr. Umapati Hegde, and the another was published from the center where I give my final DNB exam from RNR Delhi. So I chose this topic today for presentation. First, I would like to give a short case summary of the case which we had a couple of years before. Then I would like to go in details of pathophysiology of parvovirus infection, then the impact of parvoviral infection on a post-renal transplant patient, then the management, and I will share the paper which was published from our institute, and then we'll give a take-home message. So this is a summary of the case. A 37-year-old male with chronic kidney disease stage 5, end stage, with native being IgA nephropathy, underwent renal transplant with 66-year-old mother as a donor. No prior sensitization history. Patient received basiliximab as induction, was started on triple drug immunosuppression regime, including tacrolimus, mycophenolate, and steroids. Nadir create achieved was 1.4 milligram. Hemoglobin was 10 gram on 8 post-transplant day. And the patient was discharged in pristine condition and stayed wonderfully well till 1 month of post-transplant. At 1 month, patient actually had a precipitous fall in hemoglobin. So on hematological workup, actually patient had 1 gram fall of hemoglobin per day, no fresh blood in stool or occult blood. Patient was iron sufficient and no rise in creatinine. Blood pressure was also fine. Reticulocyte count was 0.2%. Peripheral smear was suggestive of severe normocytic normochromic anemia, and other cell lines were okay. And we sent Parvo virus B19 DNA PCR. It showed more than 10⁹ copies per ml. So I would like to go in the details of pathophysiology of parvovirus. It's an erythrovirus of parvodensovirus group. It's a non-enveloped, very small single-stranded DNA virus. And the most common parvoviridae family virus is from genus 1, which is called parvovirus B19. So there is a reason behind this name. It was discovered accidentally in 1975 as a blood donor who had false positive HBV status detected by PCR method. And the batch was B batch and the sample number was 19. So it was the virus which came to be known as parvovirus B19. The association of the same virus with clinical disease was found out in 1980s. It's a virus which contains 2 structural proteins, which is labeled as viral protein 1, viral protein 2, and 3 non-structural important proteins, NS1, which is responsible for cell cycle arrest at G2 level in erythroid precursor cells, and NS2, which causes apoptosis. This virus has cell tropism for CD36 receptor, or it's also known as globocyte receptor, present on the erythrocyte colony forming unit and erythrocyte blast forming unit, which are the precursors for reticulocyte and RBCs. There are some modes of aglobocytic infection also in placental trophoblast, endothelium, megakaryocytes, and cardiac myocytes, but they generally act as a reservoir for this virus, and they generally don't throw significant clinical syndrome. So this diagram is a representation of infection of parvovirus B19. Here we can see that the virion gets attached to an erythrocyte precursor cell with the globocyte receptor, and it is mediated by viral protein 1. Then viral protein 2 mediates the entry of the cell in the cytoplasm, but the most of the replication of virus and viral DNA occurs in the nucleus. It forms the NS1, NS2, NS3. The NS1 binds and blocks the JAK-STAT pathway, and it prevents the hypoxia response elements, which actually stimulate the erythrocytosis. NS2 actually causes the apoptosis of the cell, and the cell bursts and the virion gets released.
Akash?
Sir, there is some issue with my net. Just give me a second, sir.
Yeah. Okay, that's good. Okay, take a few seconds. Okay.
Okay, back, sir.
Yeah, fine.
So this is the classical appearance of the parvovirus B19 infected cell. On left, we can see that here we can see that this is a pro-normoblast in the bone marrow with glassy intranuclear inclusions, and generally the bone marrow is hypercellular. There are very scarce or very few late erythroblasts. Sometimes they are absent also, and the other cell lines in bone marrow are generally unaffected. If we go into the epidemiology of parvovirus B19 infection, we have to understand three different epidemiologies in three different type of patients. So in an immunocompetent host with normal RBC lifespan of 120 days, when virus comes, it generally gets into the system by respiratory route, by droplet or fomite infection, fomite route. And generally 4 to 6 days are incubation period. After that, patient gets some flu-like illness. And during that time, the viral DNemia is evident. But by the end of second week, IgM antibody appears, and they are protective. And by the end of second week, generally the viremia disappears in a healthy individual. After that, there is arthalgia, and in children we can see fifth disease, rash. Those are immunologically mediated symptoms which we see in an immunocompetent host. Generally, we see mild hemoglobin fall, but significant reticulocytopenia, because even though the RBC production is halted or reduced, because of the good lifespan of RBC, we generally don't see fall in hematocrit. But in case of hemolytic patients who have sickle cell anemia or T.Raja, in those patients, what happens is when this erythrocytosis is halted, there is significant fall in hemoglobin, but they are immunocompetent. So by 2 to 3 weeks, the immunological response takes on, and it takes care of the infection, and patient clinically improves and generally comes out of a severe anemia by the end of month. The problem occurs in immunocompromised host when the patient has normal RBC lifespan, but they cannot clear the viremia. The antibody response is delayed and sometimes absent actually, because this occurs when the immunosuppression is, the net immunosuppressive state is suppressed maximally in the early months of transplant. So they don't clear the virus, the antibodies are not there, and the chronic pure red cell aplasia sets in. So there are multiple diseases which can occur with viral infection, like fifth disease, arthropathy, transient aplastic crisis, chronic hemolytic disorder, fetal infections. But what we want to discuss is pure red cell aplasia in immunocompromised individuals like renal transplant patient. This is because of decreased ability to mount an immune response. The important immune response for just like any other viral clearance is humoral immune response. And this can lead to hypoplasia or aplasia of erythroid cells. It can also occur in leukemias or cancers or patients with other immunodeficiency like HIV. But now with good antiretroviral therapy, it is rarely seen with advanced with HIV patients. In a retrospective study of 98 transplant recipients who developed post-transplant parvoviral infection, the median time to onset of disease was 7 weeks after transplant. The anemia was the most common feature in 99% of patients. But some patients actually had leukopenia and thrombocytopenia also. Some patients had multiple viral infection at the same time also. Parvovirus is associated with hepatitis, myocarditis, pneumonitis also in few patients. So immunocompromised patients with parvovirus B19 infection generally do not manifest the classical immune-mediated symptoms like rash or arthralgia due to inadequate immune response in those patients. The frequency of parvovirus, parvoviremia among the immune-compromised patient may be underestimated. So in a study of 60 renal transplant patients who underwent NAT for various opportunistic virus infection in first year post-transplant, 10% had B19 viremia. The majority of cases were reactivation as opposed to primary infection. And anemia was not more frequent among the patient with parvovirus B19 compared to those patients who didn't have parvovirus B19 viremia. So routine screening for parvovirus B19 viremia by nucleic acid amplification test might not be that helpful. So how do we diagnose? So in the presence of IgM antibody and serial rise of 4-fold in viral protein 1 IgG antibody, it is diagnostic for acute infection in immunocompetent patient. Nucleic acid amplification test may not be beneficial as till the second wave of symptoms, the individual may clear the viremia, which is exact opposite of immunocompromised host because antibody response may be delayed. So NAT-based test in patients who are symptomatic, have reticulocytopenia with normocytic normochromic anemia are considered diagnostic. So DNAmia with presence of clinical symptoms is diagnostic for parvovirus B19. And generally the DNAmia is very significant, more than 10 raised to 9 to 10 raised to 10 copies per ml. But DNAmia in absence of clinical syndrome is not considered a disease or neither require treatment even in a patient who does not have who didn't have clinical syndrome of red cell aplasia ever, or a patient who is on follow-up for parvovirus induced red cell aplasia. Sorry, 5% patient with parvovirus infection may be from other genus of parvoviridae family. So those patients who are parvovirus B19 CBNAT negative and still have pure red cell aplasia, we should consider doing bone marrow because there might be genus 2 and genus 3 which can also cause red cell aplasia. And we might find the classical picture of pronormoblast, giant pronormoblast, which confirms the diagnosis and the treatment remains same. So what are the management guidelines? Reduction of immunosuppression should be attempted. It should be the first step at the time of diagnosis. Patients with parvovirus B19 infection may be treated with 400 mg per kg per day of IVIG for 5 consecutive days. The total dose is around 2 gram per kg. And a shorter course with higher dose of immunoglobulin is also recommended. This is taken from the treatment in HIV patients who are given this high dose in 2 to 4 days of 1 gram. But the results are comparable and there might be higher chances of nephrotoxicity with this higher dose. The recurrence rate is also high, but there are no data to support the systematic preemptive use of additional courses of IVIG to prevent recurrence, specifically in patients who are going to receive or who have received higher immunosuppression. PEG cell transfusion as per clinical requirement should be given. So what about the vaccines? Vaccines related ADRs in insect cell derived vaccines are seen and the development in that field was halted because of the same. But currently Saccharomyces are being investigated to generate viral protein vaccines and they are appearing promising in mouse models. So we are waiting for the vaccines to come. Till now there is no vaccine available for parvovirus B19. This is our experience. A paper published in the Journal of Transplantation, parvovirus B19 disease post-renal transplant patients with refractory anemia. This was a case series of 20 patients. We reviewed all the transplant recipients from 2013 to 2020, and we found 20 patients who were found to be positive for parvovirus B19 and had severe anemia. So parvovirus B19 polymerase chain reaction was done for all the patients. And bone marrow examination was also performed on 8 patients. The prevalence of parvovirus infection in our series was 2.16%. It was 20 out of 924 patients. The median time to onset of, am I audible, sir?
Akash, go ahead. It's a very,
Go ahead. We are hearing.
You're going.
The median time to onset of parvovirus B19 disease was 39 days post-transplantation. And clinical presentation include fever, generalized weakness, dyspnea, myalgia in some patients. But most important was weakness and exertional dyspnea. Anemia was the most common clinical finding in 100% of patients, and few had leukopenia and thrombocytopenia also. 50% of patients of parvovirus disease had graft dysfunction, evidenced by 30% elevation in serum creatine. Actually, this dysfunction might not be because of parvovirus. Most of the patients were those who already had rejection and received rescue immunosuppression for rejection, and after that they developed parvovirus infection. 5 patients developed parvovirus B19 after treatment of acute rejection, and 4 patients developed acute rejection after reduction in immunosuppression for the treatment. Almost all patients had positive parvovirus B19 PCR, and remaining 1 patient had typical giant cell on bone marrow aspiration. But we could not find any laboratory which was doing PCR for other genuses of parvovirus. So we treated the patient empirically, and patient actually improved. So IVIG, PEG cell transfusion, erythropoietin therapy were also used, and 2 out of 20 patients had their graft loss in the follow-up period. This is a paper published in another journal, which is also Indian, and it was also a retrospective case series, and it was a 10-year retrospective study of almost 714 patients who underwent renal transplant from 2011 to 2023. They had 7 patients who developed parvovirus B19 infection, and all of those patients received induction, and the incidence rate was 0.98%. It was 5.43 per 1,000 patient year. The median duration for transplant to development of anemia was 6 weeks. Mean fall of hemoglobin was 2.8, with plus or minus 1.5 being the range. Few patients had leukopenia and thrombocytopenia also. So here we can see that the percentage of patients having leukopenia and thrombocytopenia was higher, because in those patients, almost all patients received induction immunosuppression in form of ATG. In our series, actually, 50% of the patient received some form of induction, and 5 of those 9 patients actually didn't receive ATG. 3 patients responded to a reduction in immunosuppression, and 4 non-responder required the administration of low-dose intravenous immunoglobulin. The mean duration of initiation therapy to a sustained rise in hemoglobin was 7 weeks. My take-home message is parvovirus B19 is to be considered a cause of reticulocytopenic anemia post-transplant or any immunocompromised patient otherwise. It commonly occurs in early phase of transplant when patient's net immune state is significantly suppressed. There are some antivirals like foscarnet, cidofovir, which we can try, but there is no direct antiviral therapy. Reduction of immunosuppression and IVIG are cornerstone of therapy. Patient may require PEG cell transfusion depending on the clinical requirement. Clinical feature and PCR are useful for a diagnosis, but clinical scenario and the serial monitoring of hemoglobin are the guide for therapy. And if we want to reintroduce the therapy, it can recur, can indirectly cause rejection, or can happen as a reaction to rejection also. Thank you.
Thanks, Akash. I must thank Hardik Patel for for introduction. He facilitated with you. You did a great job today, and it's a complete coverage. You started with the basics of parvovirus, then went into your study, and you gave a lot of take-home points. Now, Chandrasekaran is not there, and Ram, can you unshare the plane?
Well, I am here. Well, I am here.
Oh, sorry. I think you did a very nice job. You did a very few things about the anemia not associated with parvovirus. I think he said routine parvovirus and the PCR is not required. That's the point you made it. When the anemia in the absence of clinical symptoms need not treated. This point you made it very clear. And 5% of the people you have to go for a bone marrow where you get a classic intracellular inclusion in the and the progenitor, pro-normoblast inclusion. So he made a beautiful points, and he treated. He gave some kind of treatment idea also, and his own study also shares only 5% he required bone marrow. Only one patient out of 20 required bone marrow, and you said guiding principles for the follow-up therapy also. So thanks, Akash. Thanks for it's a short notice. You came and helped us. Thank you once again. I leave it to Panelists to conclude. And Ram, make a quick conclusion, Chandrasekaran.
Okay. It was a very nice presentation from start to end. I think he covered all of parvovirus.
Can you unshare the slide so that we can see somebody talking? Yeah, thanks.
Okay. See, reduction of immunosuppression, is absolutely mandatory. But what we found out, we had around 3 or 4 cases in these years, in all these 20 years. We have to stop anti-metabolite. So first, reduction of CellSupt or mycophenolate sodium doesn't help, because even with IVIG, whatever 400 milligram per kg after 5 sessions, we keep doing DNA PCR. It goes on increasing, and hemoglobin goes down to 2.5 in our patients. But it's more common in pediatrics than in adult population. That's what our experience is. Out of 4, we had seen 3 are from pediatric population.
No.
And most of them follows. Yeah, that's what we noticed. And without stopping anti-metabolite, the anemia doesn't improve, even with IVIG. That's what our experience is.
So AST guideline 2019 also suggests to first to reduce anti-metabolites, sir.
We reduce and we have to stop.
Stop also. We have to stop also. And then we start IVIG.
Yeah, that's true. Andrew?
Yes, sir. Just a query to the presenter. A very nice presentation, sir. Regarding post-transplant anemia, at what threshold will you check for a parvovirus serology? What would be a threshold for testing? Because incidence is very less, only 2% you mentioned, if I remember right. So when do we test for parvovirus in the setting of post-transplant anemia?
So first is, sir, the precipitous fall is very significant. Even if you have hemoglobin of 13 post-transplant day 30, and you are finding that your 3 readings are going down by 0.5 to 1 gram in a day or 3-4 days. Because if patient has got parvovirus B19 infection in bone marrow, his or her erythropoiesis literally stops. So when you find that there is no loss of blood from any other side, patient is not hemolytic, and he or she is still having a precipitous fall, then you should not wait for hemoglobin to fall below a threshold.
Okay.
So the fall is more important.
Can I join?
Yeah, please, sir. Please, sir.
See, what happens is that if in a post-transplant period, if there is a drop in the hemoglobin precipitously without raising in the reticulocyte, should give you a clue that it could be parvo. Because in a classical hemolytic anemia, you start seeing retics going up. Here, in this case, your retics won't go. So that gives you a signal that it's probably a parvo. That's where you probably have to go in and check.
Okay, sir.
That's why you said it's a reticulo erythrocytic fall. Okay, sir. Andrew, please go ahead.
Just one more question, sir. Like we know that CMV and BK virus causes graft dysfunction, but such a similar situation, is it seen with parvovirus also, or is it not very common?
No, sir. Parvovirus is not a nephrotropic virus. But generally what happens is, if patient's net immunosuppression is very strong, so patient can have multiple infections also. 2 of our patients actually had CMV plus parvo. Okay. So that can cause renal dysfunction directly. But parvovirus itself does not cause graft dysfunction.
Okay. You mentioned 2 cases you lost the graft function. What is the reason for that, sir?
Rejection, sir. After first patient was being treated for rejection. And then patient had parvovirus and virus, and we had to reduce the immunosuppression, and patient lost graft to rejection. Another patient also had rejection after reducing the immunosuppression.
Fine.
After we tried rescue, but patient lost graft in 1.5 years. So the most common cause of graft loss after parvo is also rejection.
Yeah, thanks.
Arvind, Dr.
Vilas,
Naik wants to join.
sir, please, sir,
Naik.
please, sir. Yes, sir.
Yeah, give him a chance.
Yes, sir. No, the sir has raised a hand, sir. Vilas, sir.
I
Are
think
you
he's
around?
muted. Somebody had to unmute him. Okay.
Yes,
yes.
I got muted. My very
Hi,
little experience with 4 patients. The last one really baffled me. So 47 female husband donor, complete mismatch, thymo induction 2.5 grams. At the end of 4 weeks, she started dropping her hemoglobin. So previously I'd burnt my hands, so I stopped metabolites immediately. Then we switched from tacrolimus to cyclosporin, because in the previous cases I had done everything and the last thing had helped. So I tried this first. So we started on IVIG, and at the end of nearly 4 gram per kg body weight, she responded. So we further went down on our cyclosporin, further dose. It took me 8 months for this patient, and the total dose of IVIG I gave was 17.5 grams per kg body weight.
Sir,
Yes, I'll complete it.
Okay, okay.
In the meanwhile, luckily, the patient was holding her creatinine up to 1.4, 1.5. When we further came down on cyclosporin, the creatinine got raised. So with some hesitation, I biopsied her, and it was a plasma cell rejection. Plasma cell rich rejection. Now it was nearly 9-10 months. And I introduced hesitantly 25 milligrams of azathioprine. And probably my cyclosporin levels increased from somewhere 80 to 110, 120 probably. That's it. Like, I was very, very hesitant because of my previous bad experiences with this virus, which one of my patients had lost life. So with 25 mg of this, I had done her Parvo B19 PCR 19 times totally till date. And then I just monitored it a month later, and it had come down from 10⁴. It increased to 10⁻11 again. And I again stopped azathioprine in the meantime, but she started dropping her hemoglobin. Again, my cycle started of IVIG. So finally now, her creatinine is at 1.9 with this existent plasma cell rejection, which I did not treat. And she's on 30 mg BID of cyclosporin. And somehow she is holding on now. It's been like 28 months post-transplant. So that's my disastrous experience.
30 milligram of cyclosporin, Vilas?
30.3 ml of RPM in syrup.
Yeah, 30 milligram per. Okay.
30 ml total. BID.
Yeah, got your point.
So target of cyclosporin is up to 70, 80.
Okay.
So that's my very disastrous.
Okay. Akash, any comment?
Yeah. Sir, you have seen 4 patients of parvovirus. That means you have transplanted more than 200 patients, sir. Congratulations for that. Secondly, sir, what was your target for? You did DNA PCR for 19 times. What was your trigger for doing DNA PCR, sir? Was
the first one obviously was anemia, which I did not wait too long. The second one was at the end of 4 weeks. I just repeated the PCR just to be sure that the viral this going on, because hemoglobin had stabilized by that time, and then I had some academic interest. Believe me. Yes. Then again, when I started reintroducing something bad, half a tablet of azathioprine or took some risk with antimetabolite after 4 months. So I said, I will repeat it and see. So again, the recurrence, relapse. This kept on happening for nearly like 14 months. So I had to kept on repeating it. The last one was after like 4 months ago, just to see her hemoglobin is at 10, 11, just to see whether it's coming up or not, because it was my academic interest, no real clinical implication. Okay. Just to understand myself, I had a patient who had a really bad course in front of me. I did some extra levels, very frankly. So many were not needed.
Okay, now I think many people are having. Shakti, you want to add anything?
Yes, sir. Sir, just wanted to add a point. Recently, I had a patient who had parvovirus positive. Classical picture, just like how Subba sir described, patient had low reticulocyte counts with sudden anemia, joint pain, a classical presentation. I sent DNA PCR initially, came positive. Then the point which was told by our hematologist, Dr. Subba, was that initially it will be advisable to send serology test along with PCR. In case PCR turns negative, if serology is positive, he's suggesting that you have to look for the genotyping. Why? Because there are 3 genotypes in India, predominantly in parvovirus. Genotype 1, 2, and 3. 2 is almost negligible. Predominantly, it is 1, and rarely 15% of people can have genotype 3. So, if you are sending DNA PCR first and it turns out to be negative, there is a chance that we might miss the actual presence of the virus. So,
yeah.
Yes, sir.
Akash has pointed at that point. Any different genotype you can pick up from bone marrow. That's what he said.
Yes,
I think
it won't be picked up by serology also. That's the issue.
Yes, sir. Serology helps.
It does not. So problem is almost 90% of the individuals are actually exposed to parvovirus in their life, and more than 50% will be seropositive for IgG. So you may get IgG positivity, but it does not label a patient for having parvovirus related pure red cell aplasia as a disease. In immunocompetent patients, 4-fold rise in weekly monitoring ensures that this is because of parvovirus. When you are checking for antibodies also, with different genus, the titer differs. So when you want to be very sure that this is because of parvovirus B19 only, and there is pure red cell aplasia, the genus might be 1, 2, or 3. You should do bone marrow also together with sending the PCR. So, and you cannot monitor also by IgG or IgM levels. So AST guidelines also suggest that if you want to do both, then you do both together, bone marrow and sending DNA PCR for specifically B19. So serology, antibodies monitoring or diagnostic based on antibody in immunocompromised patient is practically also not possible, and it's not advised by AST also.
Sakti, thanks for bringing this point. It's a good valid point for discussion. Yeah. And I think if there is no more question, we can stop with this. Rajan?
Yes, sir. Yes, sir.
Yeah, please give your comments, Raj.
I'm dumbfolded with the comments and discussions.
Everything is fine. I think they have covered very nicely. We have a lot of good points to take home and put into practice. Right, Rajan? If anybody wants to comment anything on this subject.
There are a few charts are there. You want to answer those?
Oh, well, I didn't. I just it's
There
oversight.
are so many charts there.
I'm sorry, sir. I'm sorry. Oh, yes, sir. What is that? Okay. Okay. I could not say anything, sir.
Dr. Tirthesh have asked parvovirus causing collapsing FSGS. So the mechanism for this collapsing FSGS is immune mediated. So this immune mediated collapsing FSGS, podocyte proliferation and all, generally we don't see in transplant patients because patient is already immunosuppressed. What we see is rejections after treating for parvovirus infection in the mode of reducing immunosuppression. But yes, parvovirus is associated with collapsing variant of nephropathy.
Okay. Thanks for everyone as the speakers as well as the panelists. Particularly, I must thank Subba sir and sir student Khamini and Akash. I really am thankful because you joined late. I think you can bring some more stuff in future. Please think our plight of seeking a good speaker across India, and we find it difficult to at the last moment we caught you. You just obliged, and thanks for everything. And in future, we look forward to seeing you again on this platform. Thanks. And I thank panelist Andrew Rajiv ji. Are you here?
Yes, sir. Thank you, sir.
Ram and Chandrasekaran. And of course, my friend Rajan is here, and we exchange ourselves one meeting, and he does the moderation and another one. This is what the thing is going on. And I compliment the MQR people, and of course all the people who are beneficiaries sitting as patient listening us. Thank you. We will meet next first Saturday. Thank you. Good night. Subba Rao sir, thank you.
Good night.
Thank you.
Thank you.
Thank you, sir.
Yes, thank you, sir. Good night.
Karti, Tangabandi, thank you.
Thank you, sir. Goodbye.
Thank you.